Epidemiologist. That's a very difficult name to say, but thank you so much for making time. Dorothy Onyango is here, CEO of WAFAC, and Joyce Amondi, Advocacy and Campaign Officer at the Y Plus Global. We're still talking about the HIV and AIDS gains and challenges that we are facing. And this time I'll start with Professor Ruth Nduati, the Paediatrician and Epidemiologist. We're still talking about targeting a less than 5% mother-to-child transmission, but we're still at around 8.6. What do you think is missing?
Thank you for asking that question. I think first is to clarify that with the current antiretroviral drugs we give mothers who are pregnant and breastfeeding, when medicine is taken as prescribed without forgetting, you have less than 1% HIV transmission to the infants. So this situation we have in Kenya, where we are still above 5%, which is a measure of how everybody is doing, is an indication that we are not reaching everyone. When you look at the data, we look at the Kenyan data, there are women who are not accessing antenatal care. So they're not getting the opportunity to be tested. And then within our own facilities, when women have come and are tested and are testing positive, there are people who walk away. They walk away, maybe like there's been a recent period of time when there were drug stockouts, but they also walk away. Sometimes you need to have self-acceptance to actually take up the medications. The other, in fact, about half of the infant infections are accounted for by women who newly diagnosed and not taking their ARVs. You remember I did earlier this evening, we talked about the number of new infections are largely in young women, 15 to 24 years. Struggling with not yet fully mature, not yet really understanding the consequences of walking away from that medication for their own health and for their baby. Yeah. The other group of people who are struggling...
It's not about lack of information, is it? It's more of a state of denial.
I would say calling it denial is actually a big name. I think it's more than that. The way the PMTCT program works is that on the day you're diagnosed, we also want to start you on treatment. So even the preliminaries of understanding and even the testing, it's what we call provider-initiated testing. You say this test is part of your antenatal profile, and you can refuse it because it's a choice, but many times, you know, you're not expecting a problem, so you will do the testing. And then now, when you're faced with this big diagnosis, it's a challenge. It's like, you know, there's a shock to your body when it happens. But those are not the only people who are having challenges. There's another half of women who have been on treatment themselves, sometimes for a long time, who reach a point of just stop taking their medication, and they're not motivated to do so.
Like a treatment fatigue or something.
It's more than that. There are a number of short studies that have shown that there's quite a high prevalence of depression. Real, you know, depression, not depression related to nasema, I'm just sad, but true clinical depression. Okay. And one of the things about being depressed is the lack of motivation. And I think there's a need for more research around that, in that we know that the HIV virus has a tendency to progress towards the nervous system. So some of what we are calling depression may be much more than that. It may be actually early features of maybe dementia. Okay. And we see similar problems even with children, but you know, this is the main thing about transmission, is that failing to find everybody.
Okay. Let me bring back Dorothy on this. And Dorothy, in your book, Beyond Public Confessions, you spoke about people going to the extent of drinking urine. It means there was a time when this situation was extremely desperate. And now you said that there's a bit of progress. But the members of parliament who were sitting here earlier on were saying that we should still somehow show people the dire state of HIV so that there's a deterrence of some sort. Would that work in your view? And also you can talk to us about this session of drinking urine and what that was all about.
Thank you, Trevor. I think what I can say, Trevor, is that we are coming from a point where there was desperation. Yeah. In the early 80s, there was no medication, and if there were, they were very expensive. It was not affordable. I remember in the early 80s, it was around 120,000. Who would afford that? And at the same time, most of the people who needed that medication are people who don't have good income. People who had money could go to the shops, to the pharmacy and get medication because they have money.
Yeah.
So that is why we went as far as taking urine. I personally did. I did take my urine because I went to a meeting in Japan, and they said that somebody gave a presentation and said taking urine early in the morning, the first urine, it will help you treat HIV. So we were really desperate that anything that came out, you really have to try. Yeah. And I think this went on for so long until some of the advocates, people living with HIV, came up and we talked to the policy makers, not lightly. We advocated and we pushed for drugs to be available, and I think this happened. Yeah. So for young people who have just come in, they don't know what we went through. Yeah. Because we didn't have medication, but we lived every day because you didn't know what would come the following day. You have your children, yeah. You don't know whether you will die or leave them. Some children were infected. So we really fought as movements of people living with HIV, yeah. To ensure that there were drugs. Our children were taken care of. We even have sessions of food basket when coming to my organization, WOFAC. They would come to the drop-in center so that they can get food. Yeah. And that is the only thing we could offer because there was no medication.
And even back in the 80s, you faced a lot of stigma. So when you hear the members of parliament saying that the younger generation doesn't see the impact of HIV in terms of what it would do to the human body, do you think it was important to show them that, or is that where the problem itself started? Because now it seems like a double-edged sword where they're saying that if you don't show them how badly it can affect someone, they now take it lightly. But then if you do that, then you're stigmatizing the people infected. So how do you balance this?
I think for us it was very scary, yeah. But we had that courage to want to live on because some of us had small children. I am not sure whether that would really change, but probably we need to find ways and means of letting these young people know that there is need. And, yeah. and I think as communities of people living with HIV, we have to go out there. We have talked about resources, that yeah. We are not well resourced. But if we have resources, then we should be able to support young people. We used to have something called group therapy sessions. Yeah. And we would meet together as people living with HIV and just share our experiences. Right now, we don't have that. So probably we need to really resource mobilize so that we can come back to those things that probably does not matter, but they mattered very much to us. So things like group therapy really worked for us. We cried, we shared our issues, and, we moved forward.
All right. Yeah. Joyce, what would work? Because we know it's not just, there's a rising infection in young people. It's more than just recklessness. There's SGBV that comes with it, there's teenage pregnancy that comes with it. But what is the central message that is missing to the young people? Because this is a day and age where you'd think there's a lot of access to information. It's not about ignorance. So how is it that the spread is still amongst the young people who are supposed to know what to do and what not to do?
That's an interesting question that I'd like to first start by responding to a question that you asked Dorothy about using threats to communicate some message that would probably be packaged differently and would definitely have a different impact. I remember when I got started on medication, myself and other young people were not being told the truth on what will happen to your system if you don't take medication. And I don't mean that they were lying to us by telling us the positive thing, but they were telling you that if you don't take your medication, if you miss your medication, you will die. You miss your medication on one day, you don't die. What does that teach you? You can keep missing your medication and you won't die either way. So that's exactly what I'm saying. Like there is definitely a lot of proper information that can be packaged, should be packaged in a way that is friendly to the young people to enable the young people to make informed decisions. And that's exactly what is missing. A lot of people are making decisions for young people, deciding what they think young people want to hear, while young people are telling you exactly what they want to hear, So there's a lot of rising infections amongst young people, and just like you've said, it's not because of recklessness. I would tell you for free that nobody really walks in a sexual engagement to look for HIV. While we say, HIV is better than pregnancy, it's not that they go looking for it. It is not even recklessness. In fact, I wouldn't call it that. It is a matter of sometimes it's negligence because, of course, you're young. For young people, sex is spontaneous, and sometimes it happens without you planning for it. So cases of female condom that you have to wear some minutes before you decide to have sex do not apply. So what is really missing is the missing link is placing the young people at the center of the response. And I think looking at the agenda of this conference, we're slowly starting to realize that the young people actually do know what they want. Okay. Why am I saying this? Young people, young women to be precise, have been calling for multi-prevention HIV, multi-prevention technologies, the issues of the dapivirine vaginal ring, for example. This is the first HIV prevention method that is discreet, that a woman can use in their body for 28 days without necessarily having to worry about preventing themselves from HIV. It provides a platform that could also be used to add a contraceptive if it is accepted. And it is something that a woman is in control of. As a young woman, I'm in control of it when I'm using it. But this ring is not available to young women, despite taking 20 years of research to make this kind of tool available to young women. So this is the kind of gaps that we are talking about, that we know what works, science has proven what works, but then these innovations and these commodities are still not in the hands of those who do need them. And that's just the first thing. There is the aspect of commodities. Then there is the aspect of information. How do we package this information? I constantly say not all young people are on social media. So that is the first thing we need to demystify. We don't all have phones, and if we have phones, we don't all have data. And to some of us, we have to, choose what is more important. Do you want to eat today, or do you want to go online on social media? So those are some of the things that we need to look at. The constantly growing digital divide that is also gendered to an extent. That is an overall assumption that all young people know this thing, all young people know where to get this information. But that's not the case. But there's also the young people. The last time I spoke to you, said that diagnose people based on what they see. Yes. They look at you and say, this one is definitely good. Yeah, I mean, there is that aspect of, when you first meet Trevor and you look at Trevor, you're like, I could pass with that one. But then that also depends on what passing means. So if I come to screen you with my eyes, that means I'm not very well informed that there is no HIV testing method called screening you with my eyes. And mostly it's because young people tend to think they already know. And that is exactly, it takes us back to that conversation that the members of parliament just had. The picture they painted of HIV is totally different from what you expect when you're meeting someone living with HIV. If you're expecting to see me with oogled eyes and all those things, that's not going to happen, not in this day and age, not with DTG being present and with more new treatment options being available for people living with HIV. So those are indeed, it also just really shows a glaring information gap. And while people will be tempted to call it recklessness, in ignorance, it's mostly because ignorance occurs when you don't have the information totally. And that means that some of us who are in the response are not doing what we are supposed to do. But negligence occurs when you know what you're supposed to do, you choose just not to do it. So language is also a very important aspect of it. Prof, you wanted to jump into this before I bring in Dr. Maisha.
I want to jump into this, and you'll probably call me very conservative, but this is important. If you look at the Kenya Demographic Health Survey data, which picks up data on, it has consistently asked the question about whether young people, young adults, so it looks at both the 15 to 24-year-olds, whether they have comprehensive knowledge of HIV. Consistently, only 1 in 2 young people who are that age group or who are finishing Form 4 are knowledgeable. What this says to me, this says to us, is that the young people are in school to be prepared for life, to be prepared to grow up to be the lawyers, the doctors, the farmers, the parents, etc. And I'm posing that our education system is failing in a very primary duty, in that young people are leaving high school without sufficient knowledge about health, the things that is important for them as individuals. Yeah. And this lack of information is not limited to a lack of comprehensive HIV knowledge. It's even health-seeking behavior. You see young women, young mothers of young children, showing up in hospital when a child is dying. For example, Kenyatta National Hospital, we have a very busy peritoneal dialysis program. Of, dialysis because the kidneys are packed up. And there are young little babies whose mothers showed up so late when a baby has not been feeding for 3-4 days, has not been passing urine for 3-4 days, you're still at home and you don't show up in the hospital. And when you talk to them, they're completely ignorant. So, and it's not one person. Yeah. So clearly there's a gap in what we're doing. And in fact, as we were preparing for this meeting, I was just saying, we need to put the in charges of schools, the headmistresses and headmasters of these high schools, on performance contract, that a child should not leave school without that information. Okay. The 4 years of secondary, or from primary school to secondary school, does not add value in terms of this knowledge. Okay. So there's that lack of knowledge. I think the other is there isn't a very broad awareness about how the human brain develops. Okay. The level of thinking, what we call the ability to see what your actions for today have a consequence for tomorrow, which is the highest form of thinking a human being is able to engage in, doesn't develop until you're about 23, 24, 25, 23 years, 22, 23. The girls are a little ahead because their development is usually a little ahead, 2 years, than the young men. So even as my dear 15 and 16-year-olds saying, I know what I am and where I am, the truth is that they don't. Okay. And the truth is that they don't fully appreciate the consequences. Okay. It's not their fault. The brain hasn't grown. It hasn't gotten there. And so there's the need then for parents and teachers to be in that space, to walk along the kids as they're growing. Okay. We tend to say, now because a girl has boobs and a nice backside, or the young man is tall, we assume they're grown up. And we leave them. We leave them out there, but they don't have that. They don't have what it takes. All right, Prof. Yes.
Let me bring in on this. Kindly start with your name and tell us, how then do we bridge the gap going forward here?
My name is Jero Plimo. I work in the HIV response, and I work with young people. I think I'd just like to pick up on what Dr. Ruth mentioned and what Joyce has mentioned. A key aspect is creating a space for young people to be co-creators in programs. And I constantly even say, as an adult, you've been a teen before, it's okay. As young people, we do not deny that fact. But you're not a teen now, you're not an adolescent now, you're not a young person now. So what does that mean? It means creating a space where you can co-create with young people. Yeah. I agree, maybe we are not able to really perceive the risk or the consequences, but an opportunity for us to be able to co-create. You guide me, I guide you, I tell you this will work and this won't work, is really important. A key aspect also in the HIV response for young people is demedicalizing HIV. Nelson mentioned that it's a human rights issue. It's a social cultural issue. And as young people, we don't see it as a risk, or rather a young person might not see it as a risk. But how do you ensure that this young person is able to have the skills, self-agency, to see a risk or to see, by the way, I don't have to have sex if there's no condom, let me go back, because it is a risk. That screening with the eyes actually is a lie, right? I don't think threats would work for young people. I think it wouldn't work, honestly. Some of us were told we will die. Of course, we were afraid we will die because we saw our young people die. But for right now, this generation, I think an important aspect is having honest conversations with them, because we are the generation of Google and researching. So honest conversations, peer-to-peer models are working, we are reaching out to young people, empowering them so that they're able to reach out to other young people.
Yeah.
We are moving from saying, come to the facility and get tested, and we are going to the community to test young people and talk to them and listen to them. The last aspect is really intersecting these issues. To be honest, Trevor, I don't think a young person is going through one issue. They're going through so many issues. And in their environment, there are so many driving forces. There's peer pressure, which is a big component. There's the life situation at home. Dr. Ruth talked about gender-based violence. Others are in unstable homes. Others want to fit in and be young and wear the latest outfit or go to the latest beautiful places. And that is us and being young in this generation. So it is really intersecting all these issues and being able to program and design a program that addresses and empowers a young person holistically, so that when you are not there as a parent, as a guardian, they're able to actually walk out of a risky situation and not feel guilty about it. Because
interesting what you're saying, Jerome, but what my question would be, and I'll open the floor to the rest of the team to speak about what they think the solutions are going forward. Which message works? Protection or abstinence?
Both would work. And this is why there are so many young girls and even young men who've not had sex. They do not want to, but they just feel pressured because if you've not had sex, you're not cool. So that's number one. It's having conversation and saying, actually, abstaining is still cool. If you want to, if you haven't, if you don't want to have sex, please don't feel pressured. You're not missing out. It's that convincing conversations. I've had sessions with girls who feel like, if I don't have sex with my boyfriend, he said he will leave me. And they're really in a position where they don't know what to do and they still want to keep this boyfriend. So it's an empowered voice really affirming them and telling them that you're not missing out and that it's okay if you don't want to have sex. Also, it's protection for those who are already having sex and demystifying the concept of without a condom, it is not sweet, because that is one of the most believed concepts, even among adults, but really showing them what is the risk on the other side.
I still have a microphone over there. I'd like to hear from the rest of the team in terms of what is the best way forward now? Which message should we be passing to the younger generation, even to the young adults as well? Yes, go ahead. Just start with your name.
My name is Maureen Morenga. I work for Kokoiju Africa. And what I want to talk about is I want to talk about the young girls who are already those who got pregnant, and then they are, after getting pregnant, and you realize that they are coming from the slum areas, they're coming from ghettos, and most of these girls, what happens to them is that there's no any other, we don't have any program that will make sure that they come out of this stigma or any other information that will help them to also fit in the society, because I'm already pregnant, because maybe I was pregnant because I did have maybe a pad, and then I went out there because I wanted to get pads from somebody, and then because of that, because of necessity, it was out of the necessity she got pregnant, and then again now after getting pregnant she has now she has another problem. She has a child where this child needs another help, because this child needs pampers. Now what happens? She now goes out to now get a pad for herself. She's going out to get another pamper for her child. What is that happening now? I have this Mbabas, I have this friend, I have that one there, and I have this other person.
And that's how it's
so when we're having our programs, and then we are talking about the youths, do you ever consider these youths and bring them on board on the table so that they can share what they are suffering from? Can they also have an opportunity where they can have, as within their areas, within their spaces, where they can also have programs where they can share their problems so that they cannot get this HIV? Because you can find a young girl, she's a mother, she's HIV positive, and she does not even have any information on how to go about it. She cannot even have a space to share with others how to go about it to stop spreading this HIV. And these are the real things that we are experiencing in the community, and these are the things that are happening, and we do not even have funding to make sure that we bring them in the same space where they can share and make sure that others are not getting HIV.
All right, let me pick like two more and then I'll come to you to address this issue. Yes.
Thank you. My name is Maureen Morenga from Lean On Me Foundation. I support everyone who says threats will not work. 30 years ago, we can't go back 30 years, when we had billboards of skeletons and we had thin people, we didn't have medicine, we didn't have the current science we have now. But I think for the young people, it's about empowering them to look at the future. Like they are the future of this epidemic. They are the ones who will take us to the end of this epidemic. So I think I'll go back to the theme of the Maisha Conference 2023 that talks about leadership, people, and then science and partnership. We need to build leadership among these young people and let them know that they're the people who will give us solutions to the end of the epidemics. We have had our generations that have suffered in the initiation of the epidemics. People lost lives, people became thin. Like Dorothy said, we used all forms of concussions. But now we have science that proves that treatment works. We have prevention commodities that work. So HIV is preventable. HIV is manageable with treatment. So what we need is leadership among the young people. We need integrated services where they go to hospital. You know, they are not sick. How do we take these commodities to the community? If I'm not sick, I'll not walk and queue at Kenyatta Hospital for 20 hours. And then we need to have some partnerships. We need to make HIV everyone's business. Ending HIV everyone's business. We are actually at the tipping point. If we tip wrongly, we go back to the 30 years and start sharing. But if we work towards accelerating the end of these epidemics, we have the solution scientifically. We just need to address the barriers that the young people are facing in terms of information and other structural barriers, stigma being one of them, and then bring this epidemic to its knees.
All right. Let me take one more comment over there. I see there's a lot of comment. I'm not sure we'll have enough time for it. Yes, go ahead.
Thank you very much. My name is Ryan Abdul, and I'm a young resident from Mombasa County. I really like how the conversations have been going on and all the new and bright recommendations as things that would work. But at the end of the day, we must not forget that all these things need resources. And day by day, we are moving closer as a country to the journey to self-reliance. Then that makes me as a young person really curious and want to understand. And as she said, we want to know because we know what we want to know. It makes me want to know what is the government doing in place and in consideration of this fact as a journey, as we're walking to this journey to self-reliance. What are we doing to ensure that our health issues, our health financing is developed and invested domestically? While we're doing that, how do we ensure that we enhance our health systems as a government to ensure that we deal and we reduce issues of fragmentations, issues of misuse of public funds? Those are the issues that we really need to understand as a government. How are we prepared to deal with this? Because if we don't do that, we won't have the resources. And then we will always be on the issues of having to deal with issues on need-based. And as we see, there are a lot of needs. There's so many needs affecting this person living with HIV, this person using drugs. And also, as a government, how are we? What are we looking into to see how we can leverage into the private sector to see how they can come in to chip in and assist and strengthen the health systems and the health networks in our country, because we've seen it work in places like Coast General Province Hospital in Mombasa. Private sector coming in to support with infrastructure. How can we then make this multiply across Kenya, across all facilities?
All right.
Thank you very
Let me
much.
just take two quick reactions and then I'll come to my panelists here for a closing remark. Yes.
My name is Matthew Sowili. I work for the US Peace Corps. And as we discuss, the main thing I want to say is the issue of inclusion. 30 years down the line, the deaf community remain behind, and those living with special needs. So even I want to challenge the programmers that as we program, as we say these good things, what do we do with sign language? How do we reach the deaf and the other special people so that they also get to learn about HIV? How do we, how can the government, for example, make sign language, say, mandatory in primary school so that people get to know basic sign language that you can use to share with the deaf community, and so that we all work together? Thank you so much.
All right. Yes, sir. Very briefly.
And for me, I'd like to highlight one point and agreeing with whatever everyone has said. Number one, the biggest challenge with the young people is we want to teach the young people. Young people don't want to be taught. They want to be reached. We want people to reach us, reach for those young people. that is the solution.
Okay.
And, until we start coming up with ways of reaching them,
yes,
that is the day we will close the tap of new infection among young people and even teenage pregnancy.
Okay.
Reach young people.
Okay.
Okay,
yes.
mine
Yes, ma'am.
is
Very
just
briefly.
to echo
what
my fellow community has just spoken. And as we are discussing about ending HIV by 2030, we need to remember that we have TB. And if you want to end HIV, we need to talk about TB, because we understand that most of the people living with HIV die out of having the TB.
Okay.
So we need to have meaningful integration.
All right.
Yeah.
Dr. Maisha, you had all the concerns from the people, and there's the Maisha Conference coming through. How is this going to address all these issues? How did you envision it?
So thank you very much. I think for the Maisha Conference is really what you had.
Yeah.
It's about looking at the science, which you've had one speaker, Maureen, speak about. We have it, the solutions. But then we also have the people. As you've heard here, we really have voices that everybody has a solution. We have partners. So what is lacking? There is an ingredient that you must really strengthen, which is the leadership. And the leadership is not leadership from up here downwards. It's the leadership from within. Leadership from young people, leadership from families, leadership from religious leaders, parents, teachers. And that's emphasis we must be. And in leadership comes accountability. Because if you lead, then you become accountable. Someone has said, let's be accountable for resources. We can see the future already. We know that this epidemic has been addressed through resources from external sources. We know the tap is drying. We know that we must be ready for what Dorothy spoke about. A whole cohort of many people living with HIV who are now aging gracefully with HIV on antiretroviral. Are we going to abandon them at the hospital door when we hear they have another comorbidity like diabetes? And that is why we then start discussing the conversation of how do we strengthen that health system to also deliver. The same way we, 1994, we said universal health coverage for HIV services.
Okay.
And we said free to the user. Similarly, that discussion needs to go back to the health systems. And we say, how do you then deliver the entire package of services, comprehensive, without removing some of the benefits to these people that we have given services for ARVs, for diagnosis, free to the user as a government. Are we ready for that? Okay. And then finally, I think I'd want to say that it's really important that during this conference, what we are seeing is that, for example, you can't discuss the progress of HIV, the multi-child transmission, without talking about Professor Ruth here, because she has been there, walked the journey. You can't discuss about stigma and resolving the orphan crisis without Dorothy Onyango. You can't discuss about the leadership movement without people like Nelson Otoma here. And you can't discuss about the youth without starting to see where Maureen brought us from, where you're picking up from Joyce, and where you're picking up from as Gerald. So what we're saying is that we are bringing people together so that we reflect, but come out of this conference thinking about that the job is done, but it's not yet done.
Okay.
We are doing well. We have done it. We don't want to rest the paper and say, oh, yes, we are there. But you're saying it is not yet done. So that we can leave this place motivated, but hoping that we are going to invest in ourselves to get a little milestone that is remaining to push the button further so that indeed Kenya can actually speak of end of AIDS. I was just speaking to my colleague from Zimbabwe who is coming for this conference, and I said, so tell me about Zimbabwe. And then I said, you know, we have the same epidemic. You have 1.4 million people living with HIV. Then I said, okay, what are your infections? He said 22,000. You know where the difference came in? The deaths. I said, so what were your deaths looking like? We always compete in Zimbabwe. Then he said, ours were quite a number. I said, how many? He said 11,000. That's almost 7,000 more than Kenya. So I said to him, you have actually gone ahead of us. So those are some of the things that when we compete against ourselves, then we begin to ask ourselves, are we really doing enough? Because we cannot lose 18,000 people in 1 year when we have the science, we have the leadership, we have the partners, and we have the people.
Okay.
We must revisit the conversation and do things better.
All right.
Thank you very much.
So, Prof, what must we do now? It seems like there's no silver bullet to this, and she mentioned that we're at a tipping point, so we might head back to where we were 30 years ago or move forward.
Well, I think we need to relook at the policy beyond this HIV field. Yeah. We need to strengthen the health systems. You know, people move away and fail to come back because of what they met. And Kenya is not absorbing its health workforce. It only absorbs 40% of, say, the medical doctors who are getting trained. And 70% of the nurses who train are not absorbed in the system. And yet the system doesn't have enough health workers. So the need to strengthen healthcare systems so that when the person shows up, they meet a compassionate, well-trained individual who is able to empower them, to provide the information, empower them to be able to manage when they go out there. That I think is going to be very critical for our healthcare systems. Okay. We need to also shift gear and start manufacturing medicines for ourselves. And Kenya is very well placed because we are at the center of a very large population of the Eastern Central Africa, about 100 million people in East Africa. So you can have viable manufacturing. Yeah. Condoms. Do we really need to be buying condoms from other places? We already make gloves and such protective gear. Why are we not manufacturing it here? Okay. And yet there's a great need. We keep saying that we are having stockouts, you know. Yeah. Manufacturing under, what do they call it, under license. Yeah. We have the EPZ zone where we're already making lots of stuff. Okay. Why are we not doing the things that actually directly benefit fellow citizens? Okay. But then, more important, I still go back to the story that we must prevent, we must empower young people. They're the future. Yeah. Eh? That as you go into the future, into adulthood, you're well empowered to avoid getting HIV infection and other STIs. Yeah.
All right. Dorothy, what would you like to see going forward? You've been dealing with this for more than 3 decades now. What would you like to see going forward?
Trevor, I think for me, what I would like to see moving forward is that people need to know their HIV status. Let us go out there and test. We cannot end HIV if people don't go for tests and know their status because they know there is something they can do about it. So really communities need to mobilize. They need to mobilize young people. They need to mobilize people who are at risk of getting HIV. Yeah. And this will need resources. So I think test is what needs to be done. All right. Yeah.
Joyce, how do we reach the young people? You mentioned that they need to be reached, not taught.
Yeah. I don't know how to start, but I wanted to also answer in the line of thought with that, and I'll tell you why. Yeah. As Europe mentioned, that even as young people, we are also currently having opportunity to also be programmers and implementers, and so that also leads me to answer the first question that you asked them, and then I'll come to you on what would I like to see going forward. Naturally, this conversation gravitated towards HIV prevention when talking about gains and challenges and milestones. But really, the focus never usually goes to those who are already living with HIV. The young people who are already living with HIV, who should be supported to attain the undetectable viral load so that it's not transmittable. And that's also, you know, treatment as prevention is one very effective HIV prevention model. So I'd like to see more young people being engaged in all diversity. Young people are not just a homogeneous group. We are not just a group of negatives and a group of positives. There's a lot more, and I think some of the young people that have spoken here have talked about that. Again, I mentioned I'm a programmer. So the UNAIDS, the recent UNAIDS report on the path that end AIDS is very clear on what is needed for us to end AIDS. It is resources, it is partnership, and it is also, multi-stakeholder and multi-sectoral engagement. And when Dr. Ruth was talking about Zimbabwe having been ahead, and also the same report highlights that Zimbabwe has actually met the 95 target. So that also means there's need for cross-learning experiences. Even from us as young people, we still also borrow the same experiences. For example, Zimbabwe is one of the countries that quickly adopted the dapivirine vaginal ring when it was announced by the IPM that it's available. They quickly adopted it, and they did the same with the injectable PrEP. So that means that as a country, Zimbabwe has already committed and is continuing to do more, and I'm really looking forward to listening to them going forward. Finally, there is the aspect of embracing innovation and progress. We've talked a lot about new technologies. We've talked about, you know, even the new prevention technologies, but there's still even more going on under treatment. Even as young people, and even as Dorothy and team always constantly remind us that we are lucky now that we have medication. We are lucky now that we have DTG. But DTG is not also enough. DTG makes me fat. I don't want to take it. I want more options. I want to know that I can be, you know, I can be on an injection for 2 months and doesn't have to go to the facility every now and again. And finally, we need to address the main issues, the main drivers, as NSDCC likes to call them. Yeah. These are issues that we know. These are issues that we would like to address. And finally, to speak to how do you reach young people? I think we all know the answer. You have young people in your homes. Just don't force the conversation down their throats. When Prof was speaking, I wrote down, I won't argue with science. When Prof says, after years of research, we have established that at this age, the brain is not fully developed, we won't argue with science. But then how do we go around science? Because then this is exactly what is happening. This situation is happening. Young people are getting new HIV transmissions at a very young age. So how do we go about it, and how do we support? And I am glad that in her parting shot, she also said that we need to empower young people. Yeah. And that's where we come in as young people. And Sami, to what Justice was saying, that we don't want to be taught. Yeah. You're not coming to me with, I know I've gone through this, I know this. Yeah. It is this and this is what is happening now. How do we go about it? Or how do you want to go about it?
All right.
Yeah.
Thank you all so much for making time. This is a conversation that we can't end now. Like Dr. Maisha says, the work is done, but more work still needs to be done. We'll have these conversations again soon. Dr. Ruth Nduati, CEO, National Syndemic Disease Control Council, thank you so much for making time. Professor Ruth Nduati, Paediatrician and Epidemiologist. Dorothy Onyango, CEO of WOFAC, and Joyce Amondi, Advocacy and Campaign Officer, Y+ Global, and everybody else who made this show possible. And special thanks to the Pride in Paradise for hosting us here tonight. Brilliant place, fantastic place here, and we appreciate your hospitality. All right, that does it for the Monday Report. My name is Trevor Mbija. On behalf of the entire team that worked tirelessly to bring this your way, we say thank you, good night, and God bless.